Uh, it's pretty uncommon for those patients not to have ovarian failure after going through that. I remember the first one that I treated with using egg donation, or tried to treat using egg donation back in the late 80s. They also have oftentimes if they have pelvic radiation, which some of them do, um, they have endometriums that don't respond. So, even if they had ovarian function or used egg donation, if they didn't, they're not really high prognosis, candidates for care in many cases. To Josh's very important point, not to be missed, I mean, whether it's lymphoma or I've seen it with breast cancer, downstream effects, especially on the heart, are pretty common. And they again, I think in REI, and this is my opinion, it's oftentimes forgotten because they kind of rely on consults, to clear somebody, medicine, oncology, or MFM, and there's usually comes back as something about no absolute, right? No absolute contraindication. That doesn't mean there's not risk. It just means there's no absolute contraindication that you're not likely to maybe kill the patient, but that doesn't mean that she doesn't have risk, including just survivorship, by the way. She has, I think this one had kids before, right? I think she had a couple kids. Well, she's has an active life as it is. You want to keep that woman healthy and not necessarily challenge that. Again, it's an unusual case and an unusually good outcome, but challenging for sure, and is nicely presented.
I think we have time for one more question. Any other questions?
This is Ruby. Just to answer Dr. Siegel's earlier question about what surveillance looks like after Hodgkin's lymphoma, we actually had a really interesting, similar consult to this last week. So normally, most patients after they complete their chemotherapy, about 1 year out, they get a baseline echocardiogram. Other things is just making sure they undergo like standard cancer surveillance, like for breast cancer, pap smears. They also get annual skin exams because they're at higher risk of like developing skin cancers. And the NCCN and I don't remember the other guidelines, but they have survivorship guidelines for these patients. Normally, the toxicity from doxorubicin, usually it like 98+% of them present 1 year post treatment. Just to answer Dr. Siegel's questions.
Thanks, Ruby.
Yes, thank you, Ruby. All right, well, that's excellent. Thank you very much. Danny, great job with 2 interesting cases. So thank you.
Thank you, Dr. Ebert.
All right, well, although we are a minute early, I think it would be fine now to transition into grand rounds. Just gonna check one thing. Yes, perfect. Okay, so in just a minute, I'm going to ask Dr. Sinofsky to introduce our grand round speaker. But in the meantime, with regard to attendance, we'll be taking attendance for department purposes at 8:10. So if your name is displayed clearly in the participants list, you'll get full credit. The CME coded will be distributed by the email system. And if anyone has any other questions, you can email me or Michelle or Beth at any time. And with that, Dr. Sinofsky, are you ready to introduce our speaker?
Yes, I am. It is my pleasure to introduce Dr. Vanessa Parisi, who I've known for over 10 years through our work with both ACOG and NJOGS, the New Jersey Obstetrical and Gynecological Society, of which she is president, and I would encourage all of you to join if you're not already. Dr. Parisi is a graduate and former Global Health Academic Medicine Scholar from the New York College of Osteopathic Medicine. She earned her master's degree in neuromuscular skeletal sciences. She has a certificate in global health, and she also has a master's in public health. She did a residency at St. Barnabas Medical Center, and she currently serves as a hospitalist at Bassick Healthcare in Cooperstown, New York, Bellevue Women's Center, and works as a laborist at Mountainside Medical Center in New Jersey. She has expertise in perinatal mood and anxiety disorders, and she is one of 2 fetal alcohol spectrum disorder champions and social media communications chairs for our District 3 of ACOG. She's participated in teaching and medical services on an international basis and has gone to many countries to perform these services. It is my pleasure to introduce Dr. Parisi, who will be speaking on fetal alcohol syndrome.
Thank you, Dr. Sanofsky. Thank you all also bearing with me. I just got off 24 and ran in my house, so thank you for your flexibility. So before we begin today's presentation, we do ask that, I don't have any disclosures, that you do consider taking the ACOG's pre-test on fetal alcohol spectrum disorders. The purpose of this brief survey is to assess your baseline knowledge about fetal alcohol spectrum disorders. Responses will remain anonymous. No site-specific data will be shared beyond the ACOG FASD program team and grant partners. We have, as Dr. Sanofsky mentioned, I am one of two from our district. The district for ACOG is New Jersey, Pennsylvania, Delaware, and Dominican Republic. So each district has one or two, they call us the FASD champions, and we meet quarterly to create this grand rounds and to give a variety of talks and work on research throughout the year. So if you have special interests in FASD, definitely feel free to reach out. But in the interim, if you could just take the next few minutes to use this QR code to take our brief survey, we would really appreciate it. I'll start in about 2 minutes. Once you get to question 28, you can pause, but you don't have to close your browser. And once the presentation ends, there will be a few questions on the effectiveness of the presentation. We want to make sure that we are educating everyone, and if there's anything we could do to improve that, we're doing that as well. We'll give it 1 more minute. Okay, so I think we'll get started. If you're finishing up, no worries. I'm going to provide a brief overview of fetal alcohol spectrum disorders, and I'll describe the incidence and prevalence of FASDs as it is an umbrella term. And I remember when I was a resident, I knew about fetal alcohol syndrome, but I didn't really have any knowledge of fetal alcohol spectrum disorders. And the literature is evolving daily. So we'll introduce some of that. I'll speak about facts of alcohol use amongst pregnant women, describe the recommended screening and brief intervention techniques. That's the crux of my portion of the talk, and briefly propose strategies to improve outcomes. So my portion is just a clinical review. It is not to cover the deep details of the pathophysiology or the genetics, but we are most happy to discuss at a later date. At the conclusion of my review, I will actually introduce my guest speaker, Julene Zitza, and she is from the Fetal Alcohol Spectrum Disorders United, FASD United. She is one of our Circle of Hope mothers, and we are so fortunate to have her. So most of the learning will actually come from her. So we are all familiar with fetal alcohol syndrome. The term FAS was first used in 1973 by Dr. David Smith and Dr. Ken Lyons Jones at the University of Washington. We know it's a billable medical diagnosis, Q86.0 in the ICD-10. But the term FASD is not as well recognized. It's an umbrella term, and it describes a range of effects caused by prenatal alcohol exposure. And we are very meaningful with our terminology and our words because we want to always decrease stigma. So we typically use, instead of alcohol use or abuse, we use prenatal alcohol exposure. People with FASDs may have lifelong physical, mental, behavioral, and or learning disabilities. The umbrella of FASDs, fetal alcohol syndrome, this is where you get the structural and the neurobehavioral and cognitive deficits. It is the most involved end of the FASD spectrum. People with FAS have central nervous system problems, minor facial features, as you can see here, like the smooth philtrum, growth restriction, you can see pre and postnatally, microcephaly. People with FAS can also have problems with self-regulation, learning, memory, attention span, communication, and they could have a mix of the problems. So it does take a team. It takes a team of the pediatrician and the school counselor and the teachers and friends or family sometimes to recognize. But with the characteristic facial features, it is often the most diagnosed. Whereas someone with partial fetal alcohol syndrome may have only 2 of the structural or behavioral deficits. Neurobehavioral disorders, with prenatal alcohol exposure, these people might have intellectual disabilities and problems with behavioral and learning. They may do poorly in school. They could have concerns with memory and attention, and this can often be misdiagnosed. It can be confused with ADHD. There are many conditions that it can be confused in. So we do presume that many cases of FASD, particularly on the neurobehavioral side, are underreported. There's alcohol-related birth defects that primarily are structural deficits, and they affect the kidneys, the cardiac structures, and the bone. Also, some children may have deficits with their hearing. So according to the CDC, approximately 1 in 2 non-pregnant women aged 18 to 44 years old report alcohol use, and 1 in 5 report binge drinking in the past 30 days. And something you'll hear me harp on is it's extremely important to try to identify these patients ahead of time before they get pregnant. So this is where preconception counseling visits are very important, and also your annual visits. So when a patient comes in for their annual, ask them what their fertility plans are. If they're not on contraception and they're drinking, maybe you should recommend contraception, or just open the conversation with them. Maybe they're unaware of the effects of alcohol in pregnancy. Maybe it just gives you that open end to come in and have that discussion. With my patients, when I was in private practice, I would always ask them fertility plans and say, when you are thinking about conceiving, why don't you just make a quick appointment with me, maybe even a telehealth visit about 3 months out, and we'll get you on a prenatal vitamin. We'll talk about some key things, and I always discussed their alcohol use. And also be cautious with the word social drinking. You want to know what everybody's definition of social drinking is. These are just opportunities to intervene prior to the pregnancy. Also, according to the CDC, approximately 1 in 7 pregnant women report alcohol use, and 1 in 20 report binge drinking in the past 30 days. So binge drinking for women is 4 drinks or more. And I'm sure many people on this call, myself included, at some point on vacation or somewhere have had 4 drinks. That does not necessarily mean that we have a problem with alcohol. However, particularly in pregnant women or women of reproductive age considering pregnancy, that could be an identifying risk factor. FASDs are preventable, permanent conditions. So more than 3 million US women per year are at risk of an alcohol-exposed pregnancy. And 3 in 4 women who desire pregnancy as soon as possible report drinking alcohol. So again, this is just an added opportunity to have that conversation with the patient. It's not meant to be punitive. It's not to scare a patient, but there is a chance for education at this point. And we know that binge drinking is especially harmful. There have been some more recent studies and recent efforts in detecting if there are effects of minimal uses of alcohol in when a person is trying to conceive, and also in early pregnancy. And the data is skewed, but I'll introduce it in a little bit. And up to 40% of birth mothers who use alcohol during pregnancy also use at least one other substance. We know that alcohol and cannabis have a synergistic effect. And with the legalization of marijuana in many states, I know where I currently work, it's almost it's like, oh, I don't smoke and I don't drink and I don't do this, but yeah, marijuana, because it's legal. And with alcohol and cannabis being legal, sometimes there is a skewed idea of what you can use during pregnancy. So we do need to be educating our patients. ACOG has a great infographic for patient education as well, on both FASD and on prenatal alcohol exposure and on cannabis use in pregnancy. Experts estimate that among school-age children in the US, as many as 5% may have fetal alcohol spectrum disorders, and as many as 1% may have full-blown FAS. And in some parts of the country and in the world, it may be as high as 10 in 100 school district children. So that's 10%. Again, I do think it goes underreported. There is stigma associated. Sometimes physicians may not be asking the question. And we also want to talk about broaching the issue more than just the first time. We all know with COVID, there are many stressors, and sometimes when you're doing your confirmation of pregnancy and you're pressed for time and you ask about drinking, and you get that no answer, you may not revisit ever again during the pregnancy, but something may come up. Someone may lose a family member, they may lose their job. There may be some other stressor in their life that may cause it. So we do ask that you do revisit the question down the road. And what is one drink? So I'm happy after this to send out the tent card that the FASD work group has come up with. It's great we have the digital form, and then we also have paper forms if you're interested for your clinic. Sometimes just the infographic helps to show, because a patient's drink may not be one drink. We look at the size of wine glasses now. There are wine glasses out there that fit an entire bottle of wine in them. So we really do need to talk about what one drink entails. So a 12-ounce bottle of beer, a 5-ounce glass of wine, 1.5-ounce spirit. This is just something to give the patients an idea. So this is just from the Morbidity and Mortality Weekly Report. And it's just the whole reason I put this up here, I know it's a busy slide, is just to show you that we should not be making assumptions. We should not be making assumptions. We need to be aware of our own biases. And you can see here that we see that in young people 18 to 24, the prevalence of current drinking and binge drinking is higher, and maybe that would be something that we would quote unquote assume. However, we shouldn't assume that with age comes wisdom all the time. And in our highest category, we actually have 35 to 49. So don't assume that because your patient is older or advanced maternal age that they aren't participating in alcohol. Same thing based on education. There are patients with a college degree, you can see at the highest rates of current drinking. So don't make assumptions, just screen all of your patients and try to do it in a sensitive and culturally aware way. This is just another infographic which shows our region here, and we're in region 2, where the estimated prevalence of current drinking among pregnant adults aged 18 to 49 is 16.3%. So it's fairly high compared to the rest of the country. So some times I know when I was in the clinic, our nurses would do our intakes and we would say, you don't drink, right? And keep it moving. And that's not the way to have the conversation. Tell me about your relationship with alcohol. How much alcohol do you drink? Asking open-ended questions make a difference. So just a brief pathophysiology slide. So we know that alcohol crosses the placenta and rapidly reaches the fetus. The amniotic sac acts as a reservoir for the alcohol. So if we're drinking 1 drink, it's like the baby drinking 4 drinks. There's prolonged exposure, and the fetal liver cannot clear the alcohol, does not have significant alcohol dehydrogenase and other antioxidants like glutathione. So the alcohol actually has to diffuse back into the mother for oxidation and elimination, which results in prolonged exposure and ultimately higher concentrations of alcohol for the fetus. We know that ethanol and its metabolite acetaldehyde can alter fetal development by disrupting cellular differentiation and growth. You can detect the fatty acid ethyl esters in the newborn's meconium if the alcohol use was after 20 weeks of pregnancy. Prior to that, you would not be able to detect that. And in the serum, it's only positive in maternal serum for about 3 days. So you may not get a good picture of what was going on in the first 20 weeks of pregnancy. And sometimes patients present later to care. So it seemingly may be, okay, we hear this all the time, I stopped when I found out I was pregnant. And we have to be mindful of what that means. Did you find out you're pregnant at 20 weeks? Did you present late to care? And again, it's not to cross judgment. It's just to be aware of what potentially could happen. Keep our pediatricians in the loop and educate our patients further. This is also part of the tent card, and I really think it works well. We know that embryogenesis occurs in the 3rd to 8th week. We've all gotten phone calls from patients who say, you know, Dr. P, I was away at on vacation last week, or I was at a wedding last week and I didn't realize I missed my period. And, you know, I was drinking every day, or I was partying with my friends. And, you know, early on in the pregnancy, we know that major defects in bodily structure can occur. That's more of the purple side of things. Whereas on the pink side of things, we know that period of development is where major functional deficits and minor structural deficits can occur. So it just shows how vulnerable the fetus is. And I think it helps to explain to patients why, when someone is trying to get pregnant, or if they are not trying by not using contraception, that there still could be effects on the fetus. That being said, it is not my job to tell patients how to move forward with their pregnancy, or I just try to gently say, you know, well, thank you for coming to me with this information. We know that there's no amount of drinking that is safe in pregnancy, and moving forward, given our understanding that it's typically repetitive amounts and large amounts, we'd like you to just stop drinking, and we'll see you for your next appointment. So we do want to give reassurance. We can't make any guaranteed promises, but we also don't want to scare the patients or try to push them into any decisions. So just keeping that open rapport with the patients is important. So we do know that there is no safe amount, type, or time for alcohol. And there have been articles, people have asked me for imaging studies and articles and genetics, and we have a few here. We know that high levels of prenatal alcohol exposure are associated with widespread behavioral and cognitive problems, as well as structural alterations of the brain. So they actually have done MRI imaging and have seen, particularly like in the corpus callosum and other areas related to self-regulation, where they see changes in the brain. This is a fairly new study that just came out in February of this year, where in the Netherlands, the Generation R study involving 3D facial images using AI and deep learning. So there were some statistically significant differences noted in women who had even low levels of drinking. They did notice greater changes with more alcohol exposure. However, even with minimal amounts of drinking, they noticed statistically significant changes, as in turned up nose tip, shortened nose, turned out chin, turned in lower eyelids, in the 9-year-old group. By the time in the 13-year-old age group, they didn't notice that. So I do think there's work to be done, but it is interesting that they are working on that for the lower levels, because some patients will ask, well, is 1 glass of wine okay a week? And they have seen that this was significant even in women who stopped drinking after the first trimester. So women who were drinking early on or before they knew they were pregnant. So really just reiterating, there's no safe amount, type, or time for alcohol is the message here. So I also tend to use this study when I'm explaining to the patients. I think it's a pretty straightforward study that on twins that showed that nearly identical alcohol exposure in utero, obviously same mother, such as between dizygotic twins, can result in immensely different child outcomes. So we really can't predict which children will be more vulnerable than others. So we can't say, okay, you can drink, but you can't, and you can have 1 glass of wine, but you shouldn't have any. So in order to protect all fetuses, there is no safe amount, safe time, or safe type of alcohol during pregnancy. And FASDs are often not diagnosed until later in life with proper, proper people observing, the pediatrician, maybe a guidance counselor or social worker, or an outside family member. I've had teachers who've come to me and said, I noticed this behavior in the child, and since I saw your talk, now we don't want you to go around accusing everyone that they're drinking alcohol, but it may broach the issue. Maybe there needs to be a check-in on what's going on. And many women say that if their doctor would just have asked them, they would have come forward. They just felt the stigma. They felt fear of having their child taken away or getting in trouble, that they didn't speak up. But if you broach the issue with your patients, these are preventable, because there are lifelong implications of FASDs. There's billions of dollars spent with hospital fees and incarceration and trying to get these diagnosed. But with the proper team, as early as 18 months, you usually could diagnose a fetal alcohol spectrum disorder. Some go undiagnosed and some take many, many years. So FASD United is the organization we work with through the FSD work group at ACOG. We also have a member of the CDC who's on our board, who we meet with every year. And this is just a fact sheet, is not something I'm going to read to you. I'm happy to include that as well. I think this is again, infographics and brief statistics and information or fact sheets are helpful for the patients to understand what's going on. Maybe it's something you include in your confirmation. I always had a little tote bag that I gave my patients. Now things are more digital, but this may be something that you could offer to your patients, because we know that alcohol is a teratogen, and using during pregnancy can lead to lifelong effects. So the crux of my talk is brief intervention can equal prevention. So SBIRT is screening, brief intervention, and referral to treatment. It is a comprehensive integrated public health approach to the delivery of early intervention and treatment services. So basically, we want to find a quick way to identify our high-risk patients or our at-risk patients. Screening quickly assesses the severity of substance use and identifies the appropriate level of intervention. So we will go over a quick screening tool that you can use with your patients, and we actually offer it on the tent card, and we recommend that women patients are screened not only during pregnancy, but prior to pregnancy, like I said before, at preconception visits, or maybe a contraception visit or an annual visit, just getting the ball rolling. It can be timely, but we have some tips on how to get it done and the least amount of time for the practitioner. Brief intervention takes those patients that score at risk or high risk and focus on increasing insight and awareness regarding substance use and motivation toward behavioral change. So do you recognize that alcohol use in pregnancy can be harmful, even in small amounts? No, doc, I didn't know that because my mom, or I'm Italian myself, like, oh, my family makes wine. Back in the day, that was a daily thing, in a generation before us to have a small glass of wine every day. So when I give this talk in the Dominican Republic, it is received very differently because culturally things are different elsewhere sometimes. And it's not to punish, it's not to accuse but it's to just make people aware. Maybe they weren't aware of the effects. And also just saying, are you interested in stopping? We see this with smoking. I have had patients who say, doc, this is all I have. This is my 3 cigarettes a day. This is the best I can do. And, we commend them on weaning, but we have the conversation. Is there anything else we can do to maybe get you to wean more? Is there a reason why you need to smoke the 3 cigarettes a day? And sometimes the conversation ends. If the patient is unwilling to change, then you have to counsel them on the risks and move forward. It's not our job to be punitive, and we need to, when it is necessary, we report. But we just want to keep that open lines of communication in the report. And then take those patients who are motivated, who are at risk, and refer them to the appropriate treatment. And it has been tough since the pandemic and places shutting down or everyone going virtual. Trying to reach people has become increasingly difficult. And there's plenty of articles out there about that. But we want to give you some opportunities to know where you can send patients if you feel that they are in trouble. 97% of pregnant women surveyed felt it was appropriate for their providers to screen them for alcohol use at prenatal visits, and 99% said that they would disclose their alcohol use if screened. I found that study to be interesting because sometimes you assume that patients would keep it in, but a lot of these women and patients are looking for help. They're looking for someone. They know that this is not where they want to be, but they need that help and that someone to lend a hand to them to pull them out of it. So we want to screen every patient again, harping on the prenatal visits and including subsequent visits, and screening for other substances as well. And that does not necessarily mean a UTOX. I know that we are moving away from universal drug screening, but screening is having the conversation and identifying high-risk patients. Studies have shown that brief interventions for at-risk alcohol and drug use are significantly more likely to occur if the people are screened with a standardized validated instrument. So audit is what we prefer to use, and we recommend. CAGE is not sensitive for women or members of the BIPOC community, is what we received at training. And I've tried to look into that and actually went back to the work group and said, like, is there specific data we can see? And they haven't been able to come up with much. So we don't use the CAGE questionnaire, and TACE as well can be used, but we do prefer the audit. We find it to be the least biased and easiest to use. Evidence shows that high rates of screening can be achieved if such screening is integrated into clinical settings, existing care processes like your EMRs, or training your MAs or your LPNs or your RNs to do this screening so that, and maybe it's already put into your EMR. Maybe there's an iPad they use in the clinic or even on a piece of paper that gets sent to you. So you don't have to worry about the tallying, similar to EPDS, right? You're doing the screening, you get it, and then you have to decide who you have to intervene with, just to save a few moments of time. So this is the screening tool. So just 3 questions. How often do you have a drink containing alcohol? How many units of alcohol do you drink on a typical day when you are drinking? And how often do you have X amount of drinks? So 4 is binge drinking for women, and for men over age of 65. So for a pregnant patient, any score 1 or above is considered positive. For non-pregnant, greater than or equal to 7, and that's for at-risk drinking. So brief intervention, again, can equal prevention. We want to raise the subject, acknowledge it. Are you aware that drinking like this during pregnancy is a concern? I had a patient who I spoke to, I was covering in the clinic the other day, and she said, well, I was having a lot of headaches in the beginning of pregnancy because I used to drink a lot and I completely stopped cold turkey. And I could have stopped the conversation then, but instead I said, wow, that's a really great accomplishment. Thank you for sharing that information with me. How do you feel about stopping alcohol? Well, I feel really good about it. I have more energy now. Do you feel like there are stressors in your life that could make you go back to alcohol? I think so sometimes, but I feel like I'm doing pretty well. Are you going to continue this behavior after the baby has arrived? You know what, doc, I feel like I've done it and I've quit. I think I'm okay moving forward. And I said, okay, well, there are resources available should you need them afterwards, because being a new mom is stressful. And these are just little things you can have and establish that rapport with patient. Whereas when I first started, I was a little bit shy of asking these or didn't feel comfortable. And now I feel a little bit more empowered to, 6 years out of practice, that I can have that conversation with the patients and establish rapport. So providing feedback, personalizing it, showing that you're concerned, sitting down. We all know that sitting below the patient, not standing or towering over them or seemingly punitive or authoritarian, is very important. Building their readiness to change, setting realistic goals. If someone is drinking, 5 drinks every night, they may not go to no drinking at all, but trying to set up realistic goals, negotiating a plan, and having close follow-up with them, making sure the next appointment is set before they left, maybe having, maybe reaching out to them, maybe having someone in your office who they feel comfortable with reaching out to them do so as well. So motivational interviewing wants to elicit change from within the client. We know that it's the patient's task to want to change. You can only bring the mountain so far, right? So we need to establish this therapeutic rapport and make sure that a patient knows that we're here for them. We're not judging them. We're not trying to punish them. We're not trying to take their baby away, because these are the thoughts that are going through their mind, because they do not, the vast majority of people struggling with substance abuse do not want to be in that setting, but can't necessarily find the way out. We do not argue with the patient. We do not want to label them, and we want to be careful with our words and not use punitive or coercive terms. So on the last part of the card is here. So again, you have the audit, and it gives you some little examples of how to broach the topic. So do you mind if we talk about alcohol use? Can we follow up at your next visit to check in? Would you be willing to cut back X amount? These are all little easier ways to say it, and nicer ways and less biased ways to say it, rather than, you don't drink, right? Because of course, who's going to say yes to that? They're going to say, the vast majority of people will be like, nope, no, I don't. And then that cuts off the conversation. So open-ended questions, affirmations, really reflective listening, and summarizing. Okay, so I see that you're drinking 3 glasses of wine a night. You're interested in getting pregnant in the next month. Can we cut back to once a night for now? And then what can we do? Do you drink to relieve stress? Are there other things we can do? Are you interested in yoga? Are you interested in meditation? Can I refer you to a therapist? These are options that we can do to prevent fetal alcohol spectrum disorders. And if someone's already pregnant, you may be a little bit more aggressive with cutting back, but at least it shows that there's a method. So ACOG district directories have state-specific resources for alcohol and drug treatment, FASD diagnosis, and other supportive services. And you can find things about FASD United there too. So it's just www.acog.org/alcohol. SAMHSA, I'm sure many of you are familiar with. There's treatment locators there, and those should be updated. And FASD United was previously known as Circle of Hope, and it's a support group for women who use alcohol and other substances during pregnancy. And this is an invaluable group of women who have helped each other and helped so many women, and helped to educate providers so that we can help our patients. ACOG FASD's prevention work group, we have an e-module We on the CDC website, they have micro learnings and training courses. I would do them like in between cases. They're quick. I became involved with this group a couple years out of residency, and I learned so much on these micro learnings and by the expertise of all the people on the work group. And the Catalyst Learning Center online training modules are also helpful. And I'm happy to, I believe I sent my slides already, but I'm happy to send them again if it'll make it easier. These are just some additional resources. And then reimbursement, because you could say, okay, doc, like, you're saying all these things, but I have 15 minutes to see 2 patients. Like, what do you want me to do? And I recognize I was in solo practice for 5 years. I know the pressures of time and staying late so you can do the right thing and not getting paid for it, and the effects that it can have on family and relationships. And I recognize that. So there actually are reimbursement codes. And if you do SBIRT for 15 to 30 minutes, then you can bill a 99408. Smoking cessation has their own codes. Medicare codes as well are there. But I really do think that, you work hard, you should get reimbursed for your time, and it may be more of an incentive to take those extra few minutes. I recognize that it's difficult to do so, but maybe if you don't have the time that day, setting up a telehealth or setting up a follow-up, so a close follow-up, so you can spend the time with the patient. That's important, because we all know if a patient comes in for their annual, they're also there for their fibroids and their preconception counseling, and they want their hormones checked. Like, there's always more things than meets the eye. But just having that follow-up and having it reimbursable is nice. We worked on this paper a few years back, and it was just showing SBIRT's role in averting fetal alcohol spectrum disorder. So it gives a little bit more on the whole intervention side of things. We, one of your former DNP students, I was her one of her supervisors, and she implemented SBIRT in through St. Barnabas, which is now Cooperman Barnabas, one of the providers who does about 400 deliveries a year through their group. She did this in their office and piloted it, and it's still, it was just a pilot study, but it really was great to see it rolled out. And she educated the OB clinicians, the MAs, the office manager, and basically anyone who worked in the office on SBIRT and how to use she used TACE, and they gave it to all of their patients, and they saw there was an increased identification of pregnant women at risk of an alcohol use pregnancy. That's what we're here for, right? Like identifying who's at risk, number one, then intervening, then taking the next step to refer those to treatment. And sometimes the most extreme cases do get referred, but those women who are right in the middle or are at risk for even heavier drinking or may fall through the cracks. So we're trying to streamline the process. We want to expand screenings into the 2nd and 3rd trimesters. And then our goal is to make a toolkit to get this into clinics and just hand it off to residency programs or to clinics and say, this is what you can use. So that's my portion of the talk. And if you have questions, you can send to my email. But we do need to move on, and this is the most valuable portion of the talk coming up with our guest speaker, Julene Zitza. She is from FASD United. She received her BA degree from Willamette University and her MA in Special Education and Rehabilitation from the University of Arizona. Julene is a special education teacher in Colorado Springs. She is a national speaker at the ACOG Grand Rounds Educational Forums. Ms. Zitza has been an active member of the NOFAS Birth Mothers Circle of Hope for the past 17 years. Ms. Zitza has worked in the field of individuals with disabilities for over 30 years. So I'm going to stop sharing and let her share.
Good morning, everyone, and thank you for listening to the presentation. Our 2 sides of the presentation will be a little different. I am providing the patient perspective. I am not a medical doctor. I teach in the trenches of public education at the high school level. And this is my experience with my own children's journey. So I am here as purely a volunteer because I'm a member of the Birth Mother Circle of Hope, and I do not have any financial relationships towards this. I have been peer reviewed. I do discuss sexual abuse and alcoholism, which sometimes makes the audience feel uncomfortable. It's not going to be a pretty conversation. And the most important thing is my children have given me permission to share their story. I just happen to be one of the people who have found their voice to share the story, and my children are on their journey to get there. My outcomes are very similar to Dr. Parisi. Talk about the range of outcomes for prenatal exposure, the universal screening, which is invaluable, and very important, implicit bias and stigma, which is alive and well. So these are my first two children, Chiara Maria and Gianfranco. Picture perfect, matching coordinating outfits, hair is cleaned, everything looks lovely. But let's look at a different angle. This is Gianfranco. I took this picture before he was due for his open heart surgery. He was 3 months, and I took all the tape and the NG tubes off of him to take this photo in case he did not survive. He had a VSD that we discovered in utero and ultimately needed surgery to repair the VSD. So let's talk a little bit about what occurred in my life that led to these pregnancies. So some of the negative influences: childhood sexual abuse. My father happened to be my perpetrator. My parents were married. They started dating when they were 13. Both my parents went to college. My dad was a trial attorney, very successful. But when you have a perpetrator who lives in your house and comes to visit you every night, life is not very attractive. And in order to cope with that, I acquired an eating disorder. And that was more to deal with the stresses. But I learned I can be a quick learner on some things, that when my head is in a toilet, it's very hard for my dad to come visit me. Didn't figure that out till I was a teenager. When I went to my private university, I just switched it over to alcoholism. And then ultimately a college campus rate on my private university campus. Positive influences: college educated. I married a PhD mathematician. I had bought a house. We waited 6 years to have a child. Like, this was planned and organized. I met my partner when I was 20. We got married when I was 23. We didn't have a child till I was 27. On paper, my husband and I, we looked good. We had checked a lot of boxes off. But something we never talked about was my alcohol consumption, which was permeating every aspect of our lives. So I put this slide up, not to be proud. It's embarrassing. It elicits a lot of shame. But I want to show you the absurdity of what alcohol looks like in raw numbers. These were both planned pregnancies. If I had been screened, there's 3 questions, Likert scale of 6. I'd already maxed out at age 27 of 18. So there's no surprise that 3 years later, I was still maxing out, because alcoholism is a disease. it gets progressively worse if there is no treatment. And I received no treatment my entire life until after my son, Gianfranco, was born. So at the time of my daughter's pregnancy, I was consuming 14 servings a night. That's already way over the top of that, 4 drinks a night for a binge. But I didn't think that was binge drinking. I just thought that's how I ended every day. But fast forward 3 years, my tolerance had gone up. Those issues, which festered all of my life, only leaked out more, and it took more alcohol to keep those in check. I was up to 33 servings a night, and I got drunk and passed out and blacked out every night. It was insanity, not just for me, but for my husband. And at the time of my son's birth, my daughter was 2. She knew her world was crazy. And that's why I'm telling my kid's story, because she deserved better, as did my son. Bottom line is, it didn't matter who I was married to. It didn't matter what university I went to. It didn't matter any of those things that look good on a resume. You fill out your Vita. Oh yeah, you can sit and talk in a job interview and you sound good. But let me tell you, that does not mean I had any business getting pregnant. So this was really the important precipice. That was my first opportunity. You know, I'm a mandated reporter. If I see something going on in a family or a child that I am teaching, I have to report it. So any number of individuals could have helped me long before I entered my university and was raped. But no one did. I don't know why. But the bottom line is, I had joined a sorority because that looks good on paper. And I went to a fraternity party because that's what sororities do. And a gentleman visiting off campus from another university, he came to the fraternity party and I was involved in a rape. It involved me going to the emergency room and being stitched back together. It was a horrible experience. But my response is the important thing. My response is, if my body is another man's jungle gym, I need to protect myself. And my response was not to go get a therapist. My response was to ask for birth control. I thought, I can't control the men, but I can sure control my body. And that's what my whole life had become about, controlling my body. And even though I went to the health center on the university campus where I was raped, there was no question about what's your motivation. If you had asked me, I would have said, because I was involved in this rape and I want to protect my body. But instead, it was presumed, well, she's a 20-year-old woman, young lady living on a campus. It's normal to want to become sexually active. But that wasn't my intention. I wasn't seeking out sex. I was trying to help protect myself. So that was the first missed opportunity. And every year after that, when I continued to see an OBGYN, nothing about the trauma had been discussed. They didn't talk to me about, how do I cope? What are my stressors? Now, I know we're pressed for time, and you're not here to hear me report the research, but there is research that talks about the importance and the grand implications of maternal alcohol consumption. It's easy for me to look back and say, oh my gosh, my mental health needed to be addressed. But I didn't know to ask the questions, and I sure didn't have the answers. And people also have said to me, well, why didn't your husband do anything? Okay, so when he was attending UC Berkeley and he was getting his PhD in as a mathematician, how many classes do you think he had on alcoholism? 0. Just because you're brilliant in your field doesn't mean you know anything about mental illness or alcoholism. And so that's a misguided idea that why didn't the family do anything? Now I can tell you, he tried. One evening, we decided to take our little 2-year-old and we went out. We were living in Oregon at the time, and we went to Eastern Oregon. So we would go camping in the middle of nowhere. The intention, looking back, was for him to remove the possibility of alcohol from me. But what happens is when you take an alcoholic and you remove the alcohol at that great consumption, I not only had DTs, but I was hallucinating. And I thought people were breaking into our camper and my behavior was scaring him and my 2-year-old daughter. And so that next morning, we packed up and he drove me right back, because me without alcohol and no medical intervention was scary. So let me briefly mention cancer versus alcoholism. 2 different diseases. Cancer, empathy provoking. Alcoholism, judgment. So I have had both of these. Both of these diseases were not invited. I did not welcome them in them. They just are what I have acquired or had to cope with. So when I had cancer, I was just sitting in the waiting room going through my regular annual mammogram, no big deal, expecting, oh, yes, yes. Then they have it read, oh, the radiologist. And normally it's just the tech provider who just peeks in around the corner and says, okay, we'll see you in a year. And I'm like, da-da-da-da-da. And it was the day before the school year started, trying to check that box of what I can get done for time efficiency. And then the tech is like, oh, well, come on back. And I was floored that I had breast cancer. It wasn't expected. But you know what they said to me? We need to do some more work on this. So we have 3 appointments for you. We have your oncologist, your surgeon, and a social worker. You will have those 3 appointments tomorrow morning, because of course this was at the end of the day. So when I walked out, I was yielding this new information in me, but I had a pretty fast response time. And that social worker, she didn't say anything about the cancer. In fact, she said, I can't do anything about your cancer, but tell me about the other stressors you have so that I can support you in that. What a novel idea. Alcoholism, not so much. They're like, well, just stop drinking. Okay, if I could have done that, I would have. Treatment for cancer, treatment for alcoholism. And I didn't even know there was treatment for alcoholism. So FASD United is just one resource. NIAAA, SAMHSA, I mean, there are so many resources that I access in order to help other women. Because I can tell you, I had no intention of ever consuming alcohol when I was pregnant, ever. In fact, I swore to myself that I realized I couldn't stop. I couldn't stop. But I told myself, well, once I find out I really am pregnant, I will be able to stop. And then I found out. I delayed telling my husband that I was pregnant because I realized I couldn't stop. And I only wanted to be a good mother. I only wanted to treat my children better than I had been treated as a child. And so for that, we need support. And so my desire is to not only raise my children, but to go to school and provide support for the families, the children that are the beneficiaries of some of the trauma-based life people have. And I do it through giving back. Just last night, we had the Recovering Mothers Anonymous, and this is just one way to get help. But what I can promise you is we have treatment centers for women on the meeting, much like this format, so that when they're in treatment, they know they're not alone. And when they get out, they know they're not alone. Don't ask, don't tell does not work. So I am asking for you to please try something new. Have the words you are going to say. Your body language is going to scream louder than your words. And if you are going to take the time to ask, you have to be prepared for a yes. And so plan ahead. Know some of your local resources. I live in Colorado. There are international, national, there are so many resources, but you have to know the resource to hand it off. And so I come to you because I have great children. And you may hate me. You may detest me. You might not feel empathy for me. Okay, I'll work on that. But why wouldn't you help a woman for the children? You get to see lots of families come into your clinics and your offices. And so I'm asking you, why wouldn't you want to help the next generation for their future? My son has a 46 IQ. He will live with me the rest of my life. And he still wants to be loved and to have relationships and to be proud of who he is. I appreciate your time. These are some of the resources, and thank you.
Thank you so much, Ms. Ziza and Dr. Parisi. Thank you so much. That is such a powerful message. Yeah, well, we're short on time. I don't know if anyone will even have a question. Oh, Dr. Sinofsky does. We only have a minute left, Dr. Sinofsky, but go ahead. Dr. Sinofsky, just so you know, we can't hear you yet.
I'm sorry. Thank you very much for those impactful talks. Just one question for Ms. Ziza. Did your obstetrician ask you about alcohol, and did they try to do anything to influence the problems that you were having at that time?
Was never asked for those two pregnancies. I will also say that, my husband is a professor of mathematics at the university across the street from the hospital, right? We look the part that we wouldn't have any problems. And that is a bias that works against us.
Well, I think your words will influence many of the people in the audience, and thank you so much for sharing.
Yes, thank
Very fortunate.
Well, yes, thank you so much. Unfortunately, we're out of time, but again, we really appreciate your time this morning delivering this powerful message to us. Thank you all so much.
Thank you. Yeah, thank you so much.
All right. I hope everyone has a good and productive day.